So I misunderstood the assignment. I thought it was to present a case from an older surgeon. So this is a young patient, but I got the case from Kyle. I just thought of that on the way up, Kyle. All right.
You old enough? No, I'm too old.
He's old enough. He's down, going around. So obviously this is a very young patient, had a slip capital femoral epiphysis and ended up with reasonable hips, I guess, functional hips anyway, until he broke the right one. And this probably broke right at that screw hole where the screw was placed years prior for fixing his slip capital femoral epiphysis. So Kyle went and fixed it with the dynamic hip screw, which I'm already tired of hearing about this meeting. And then he put the drain right over the top so the x-rays kind of cover up his pore reduction.
I haven't gotten involved yet. You'll see when I do.
Oh, is that right? Oh, you haven't got. So here's the problem. Now this guy's got a femoral head. He's got a non-union of his femoral neck. He's had a previous osteotomy, and he's got an implant in there. So we evaluated this. First, we take the hardware out, make sure he's not infected, and treat him for his infection. Also, if you have an opportunity to take the hardware out and keep the patients in the hospital, it's a great time to get a little bit more invasive imaging. So the metal's not in the way, and you can get an MRI to make sure things are alive and there's no osteomyelitis or anything like that. And also a CT scan, again, without the implants in the way, can give you an idea of what you're up against, how much bone you have left to try to fix, and also can help you, as in this case, determine the rotation of the leg as well, as we talked about Thursday, Friday, and Saturday, restoring length, alignment, and rotation. It's not just about fixing the non-union. We want to restore normal anatomy as well. So with that information, plain x-rays, CT scan, and an MRI, we're left with these treatment options. And I can go back I guess I'll go back to this one. So what are the treatment options here? Anyone? If this walks into your office or is patients carried into your office with this hip, no infection now, some bone in the femoral head, non-union, previous osteotomy. So here are the options that we came up with. A girdle stone, it's always a fallback operation, if you will. You tell the patient, I'm just going to take your femoral head out and you're going to be left without a hip. I did have a kid who I think he suffered a head injury when he fell down an elevator shaft. So it wasn't quite all there, and I was speaking to his parents in front of him, and we were talking about a very mangled proximal femur. And I said, well, we could just take the ball out. And at that point, the kid stood up and started heading for the door, and he turned around and said to me, you're not taking my ball out. And he started leaving. I explained to him how we were talking about his femoral head and not a testicle. So arthrodesis, hip arthrodesis. I've done a few hip arthrodeses. I had a kid that came over from Afghanistan with a chronically dislocated hip. I've never met a happy patient with a hip fusion or a knee fusion for that matter. So that's an option, but it's not a good option. Total hip replacement, not a bad option in this guy. Just remove that proximal femur, forget about the non-union. It's a little bit of a struggle or moderate struggle to get a femoral component in the proximal femur where there's been a previous osteotomy, but it can be done. Fresh allograft, proximal femoral replacement. I haven't done that in the past. I've replaced half of a tibial plateau with an allograft. That worked out well. I don't know how well that's going to work out. And then a revision ORAF, perhaps with a valgus-producing osteotomy. So after a long consideration, we started our preoperative plan. And I think, in the past, if you guys have been to AO courses, preoperative planning was pushed a great deal. I still have my preoperative planner, and I keep it in the trunk of my car, so it's always with me at the hospital. It's always with me at home. I think it's a lost art, if you will, and I understand these drawings are actually from one of the masters of preoperative planning, Jeff Mass, who was a real genius when it came to osteotomies. But here's a part of the plan. Here's where the plate's going to end up, that derotation screw and the osteotomy that's going to be created. So not only about drawing pictures, and I used to have this great glass dining room table. One of the kids would be on my lap as I sketched out my x-rays and on the tracing paper and such. But you not only have to draw the pictures, you should include the steps you're going to take. And nowadays, many of our older hospitals have x-ray boxes in the operating room, so you can put the tracing paper up on the x-ray box, get your whole team on board. They understand what you're going to do. If they don't understand, you can refer them to your steps and what equipment you need. And so this was the preoperative plan for this patient. And then go ahead and see if it works. We used to cut these out on the tracing paper and piece them back together just to make sure it works, kind of like a dry run in your living room before you get to the operating room. And here we are intraoperatively. The osteotomy's been done. The plates and screws are in. Here's a nice lateral. This is probably a 120-degree blade plate. Make sure that blade is in the femoral neck and head. Remember, some of these were being done years ago without any fluoro. They would shoot plain films or just eyeball it. Personally, I need fluoro. And then here the patient is done quite nicely healed. The head's still alive miraculously, and he has a reasonable hip at a relatively young age. So the point of this exercise was to express upon everyone the need and the demand to do preoperative plannings for these more complex patients, to make sure you know what you're doing, the team knows what they're doing, and you have the equipment in the room to do it. Thank you.